there's not much else to say. I practiced in New Mexico before moving to Oklahoma, so that's where most of my practice experience came from. I didn't necessarily want to or choose endocrinology right off the bat, but that's where the job was opened, and I ended up loving it. So, you know, sometimes things just work out. The first supervising position I had was excellent, and took a lot of time with me, and so I felt like I had an amazing start. So hopefully you guys will have a good first situation as well. A lot of on-the-job training, especially if you go into a specialty. So you guys are all, this is your first year, right? Mm-hmm. Yeah. Okay. So can you tell me a little bit about what you've had so far?
We got it. Diabetes.
Okay. So this is the Clin Med endo section, is that correct? Okay. So you've already done anatomy, physiology. This thing kind of goes on its own sometimes, yeah. What else? What was before endocrinology? Okay. And have you had pharmacology already?
Oh, yeah. We do days. So we do like the farm for each organ
at the time. Okay, that's much better than the way I did it. So, okay. Well, we'll just get started. My plan is to start with the parathyroid glands, and then we'll take a short break. The thyroid lecture is longer, at least slide-wise, but it goes a little quicker. I think it flows a little faster. This one I think you need a little more brain power for, so we'll start there, okay? Okay, so just basic review, parathyroid glands are embedded in the posterior portion of the thyroid gland. Typically there's 4, some people have 5, okay, so that's a little bit unusual when people have 5, but that can cause problems when they're trying to remove them if they are over-functioning. So its main job is to produce a hormone called PTH. And what it does, I know this is some of its review, but it's kind of nice to have review, regulates serum calcium in the bloodstream. So there's a feedback relationship with the PTH and the serum calcium, kind of like the thyroid with the TSH and the T4. The way the PTH regulates the calcium is by working on the bone, the intestines, and the kidneys, okay? There's an indirect effect on the intestines because what it does is it stimulates the production of vitamin D from the kidneys, which then allows calcium to be absorbed from the intestines. So here is basically a picture cartoon of the same thing I just said if you're a visual learner. But you just think about it as when the calcium is low in the blood, PTH's job is to make the calcium high again, okay? If the calcium is high in the blood, PTH tries to make the calcium low in the blood, okay? By working on these 3 target organs. So what we're going to do is, the first part of this lecture is broken up with just high calcium. Second part will be low calcium, okay? Now I'm not going to go over every single thing that causes high calcium in detail. We're just going to focus in on the parathyroid glands and how they can affect the calcium levels in negative ways, okay, when they're not functioning well. So primary hyperparathyroidism is first. But when you look at all causes of high calcium, don't forget that there's other reasons. Probably what stands out to me from this slide that I would focus on clinically are medications that can increase calcium levels. Thiazide diuretics are one of the most common. HCTZ often increases calcium. The other thing I saw in practice is that people sometimes eat Rolaids like they're candy, and they'll just pop them all the time, and that can cause milk alkali syndrome, which is high calcium just from taking too many Rolaids or antacids, okay? So the first thing is just to kind of rule out from the medication list, is there something simple that could be fixed that's causing this problem before you go into all these other type of things. Cancer of many sorts can cause high calcium in the blood. The other thing I want to point out, just because it's my field, but hyperthyroidism, I see many, many patients with hyperthyroidism present with high calcium. So that's kind of something that you may not have known. Of course, you know, renal failure, there's other things that can cause it, random things like sarcoidosis. But these are some other causes, but primary hyperparathyroidism is what we're focusing on here. So differential, the intact PTH, which is a lab, helps you kind of differentiate hyperparathyroidism, different types, from the other causes I just showed you on the screen, okay? So if the PTH is high in the setting of high calcium, something's wrong, right? Because the PTH should not be high when the calcium is high. So you know that the parathyroid glands are not functioning well. So that's a pretty simple way to differentiate the cause. Now, this is a graph representation. As the ionized calcium increases, what should happen is the solid line. The intact PTH should go down. What happens in primary hyperparathyroidism is what's represented by the stars there. The intact PTH actually increases slightly with higher levels of calcium. Okay? So what causes it? Usually it's a single parathyroid adenoma. That's the vast majority of the time. Just one of those glands that's hyperfunctioning. Okay? Sometimes it's all of them, working together 15% of the time, or sometimes it's a carcinoma, but that's rare. Okay? There's also a grouping of diseases you may have heard of, familial endocrinopathies, MEN1, MEN2A. These are more rare, but hyperparathyroidism can occur as one of these portions of these syndromes. So signs and symptoms. What I would focus on, you're going to learn this mnemonic, or it's in most of the textbooks, the stones, bones, groans, and moans. But honestly, clinically, this is just not how nobody really came in and saying, I'm having stones, bones, But because usually it's caught before that, okay? Because of how much more frequently lab tests are done, it's unusual to catch somebody that presents with a renal stone, although it can happen. I found at least, it depends on what kind of areas you serve in. I guess if you serve in an underserved medical area, you could see it present in these ways. Psychic moans would be the most severe, to see it present with psychosis. I've never seen anything of that sort. But the kidney stones and the effect to the bones, like osteoporosis, would be more common, I'd say, than anything else. The abdominal stuff, sometimes I feel like it's hard to differentiate what's causing that. And so I don't feel like it's specific enough to say, oh, it must be the calcium that's off. But most people are asymptomatic, so 85% of the time it's just kind of an isolated finding you find on a lab. When it does present with stones, they're typically calcium oxalate. And you also see a gradual loss in kidney function and the ability of the kidneys to concentrate well. So you do see signs of like increased thirst and increased urination at times. Now, if you were to do an x-ray of someone that had long-standing hypercalcemia, you could find this. What happens is that there is a subperiosteal reabsorption of cortical bone, and it's best seen on a hand x-ray. But it now is in less than 10% of patients that you see osteitis fibrosa. What you might see more so is osteoporosis, depending on the age range and other contributing factors. So other labs, let's see here, that you'll need to size an intact PTH that are helpful in getting a good diagnosis is the 24-hour urinary collection for calcium and creatinine. And what that does is it distinguishes primary hyperparathyroidism from a familial type that's rare. It's called FHH. What happens here is that the urinary calcium excretion is lower, okay, because it's holding on to the calcium. Typically, it's greater than 400 per day if you have primary hyperparathyroidism. You also need to do a bone density scan on patients that have primary hyperparathyroidism. We talked about, you might think, why does high calcium cause osteoporosis? I thought that was the point. We're supposed to take calcium to help our bones. Excessive calcium actually causes poor bone formation. So the architecture is chaotic. So it's not the right amounts at the right time of the osteoclast and the osteoblast, and what happens is the matrix is not a good, solid architectural base, okay? So you do see fractures in high calcium sometimes. CMP, which just includes kidney functions as well, you want to check, and the phosphatase levels, alkaline phosphatase, which is a liver function test, but it also measures, bone turnover, and also a variety of intestinal diseases can have a high alkaline phosphatase, like Crohn's disease. So you can fractionate the alk phos, and sometimes that's helpful, and see if it's the liver, or the bones, or the intestines, and also the placenta in people that are pregnant. If they're pregnant, may have just an high alk phos because of that. Vitamin D is also a standard test to work up someone with high calcium levels. Treatment-wise, usually it ends up in a parathyroidectomy, so surgery is the definitive treatment, and you'll find that most people end up that way, requiring surgery. But sometimes surgery is delayed depending on if a person is a good candidate for surgery. I've often seen it delayed many years based off just increasing water intake and having fairly frequent labs done to make sure that it doesn't go too high. But most people do end up with surgery. So the way that that's done is a parathyroid Sestamibi scan is done, and that localizes which of the parathyroid glands, or if they're all four, you can tell, you know, if they're hyperplastic, all four, or if there's just one that's overfunctioning. And then that helps the surgeon to determine which one needs to be removed. If they're all working like hyperplastic, all four are messing up, they typically remove 3.5 of the parathyroid glands and leave half of one to maintain the blood calcium. Otherwise, you have hypocalcemia, okay? There are some medications that are being investigated, but there's not an FDA approval that I know of yet. In fact, I looked up Forteo is used off-label at times. It's a medication, it's an injection used for osteoporosis, and its function is basically it's PTH that's given. And so that's being used off-label. I cannot find that it's been approved yet when I looked it up, but Forteo is sometimes used. If you have a good surgeon, the cure rate is really good, 95%. The key word being having a good surgeon. It shouldn't just be a general surgeon or someone that does a lot of gallbladders and then comes in and does this. You need someone that's like a head and neck surgeon that does many of these. The rates are much better there. So common sense stuff, staying well hydrated, avoiding things like Rolaids if someone has high calcium, if they're waiting for surgery or trying to maintain it without it. So that's a treatment. Listed here, who should have surgery. What you'll find though is almost anyone can qualify pretty easily, at least from my experience with primary hyperparathyroid patients. It's pretty easy to qualify for surgery based off the recommendations. If you have good chance of surviving surgery, if you have good longevity, then most people just end up there. So some of the consequences of primary hyperparathyroidism with hypercalcemia, you've got the bone loss, the kidney stones, things we talked about, but I didn't mention cardiovascular complications that can occur. LVH and congestive heart failure are possibilities with long-standing high blood calcium. So these are the reasons it needs to be taken care of. So then I just included a statement from ACE, which is the American Association of Clinical Endocrinologists, that basically surgery should be considered for almost anybody who has a reasonable life expectancy and suitable operative and anesthesia risk factors. So that's hypercalcemia, focusing on primary hyperparathyroidism. Does anyone have a question before we go to hypocalcemia? No? Okay. So with hypocalcemia, I'm going to focus in also on the parathyroid's effect on low blood calcium. There's also, at the very end, I'm going to go over pseudohypoparathyroidism. That starts to get a little bit tricky and you get into some real rare stuff. So we won't spend a lot of time there. But that's more end organ issue, and we'll talk about the difference between primary and pseudo, okay? So just talking about low calcium and some of the signs and symptoms, whatever the cause. The Hallmark sign is tetany, which is just spontaneous tonic muscular contractions. Some of these in physical exams, you guys do, like, you probably learned all this stuff on what to look for with low calcium, but one of the things I noticed the most with patients following a thyroid surgery who had their parathyroid glands removed inadvertently is that they would complain of tingling around their mouth, which is kind of a random complaint you would think, but that actually fits exactly textbook with low calcium. So paresthesia is around the mouth. The carpopedal spasm, and I'm not exactly sure how to pronounce the Chvostek sign, but these also happen, but honestly I think I didn't see as much of this clinically, but this is often on test. These are, at least from my experience. The Trousseau sign is important to know. When you elevate the cuff 20 millimeters per mercury above systolic pressure for 3 minutes, it results in the hand spasming, as shown in the picture. Okay, so those are kind of the severe signs of low calcium. So one important thing is that some people get on a rabbit trail with low calcium before they actually know that it's a true low calcium, okay? If the protein, if the albumin is low in the blood, you can have a fictitious hypocalcemia. So it's important that when you see in a CMP that comes back, you see a low calcium, your next step should look at the albumin level, okay? Because if the albumin level is low, then you need to do a correction calculation to see if it's true or fictitious low calcium. So I did an example, but basically you add 0.8 to the total serum calcium for each one that the albumin is below 4. I think the calculation there is pretty self-explanatory. I'll let you guys look that up on your own time. But with diabetics, which I think almost a quarter of primary care patients are diabetic, you will see a lot of low protein because they lose it in their urine. Microalbuminuria is quite common. So this is actually fairly common to see low protein in the blood and fictitious low calcium. Does that make sense? Okay. You can also order an ionized calcium if it doesn't come standard on a CMP, but you can also, the calculation is the same difference. So manifestations of chronic hypocalcemia, you can also have heart effects from that as well as hypercalcemia, just looks a little differently. And like you might expect, osteoporosis is an issue with low calcium. Osteophytes, calcifications, even ossification of ligaments can occur with low calcium. Cataracts is something I would kind of star and remember, but low calcium can cause cataract, and a yearly eye exam is needed for people that have troubles with low calcium. There's dermatological issues as well that are a little more rare. I haven't seen the impetigo herpetiformis or the pustular psoriasis in these issues, but they can occur. Dental issues, you'll see hypoplasia of enamel, and then severely with low calcium levels over a long period of time, you can see calcification of the basal ganglia and even seizures. So causes of hypocalcemia, remember we're kind of just focusing in on what the parathyroid glands, when they're not working right, how they can cause hypocalcemia. Think of that as being, it can either be congenital or acquired, kind of keep it straight in your mind. Surgical is the most common cause. So someone that goes in for a thyroid surgery, this is kind of your classic presentation of someone with low calcium. Has their thyroid removed, and the parathyroid glands are damaged in that process, or inadvertently all of them are removed. Oftentimes, a parathyroid gland will be inserted in the forearm to help maintain calcium levels when a thyroid surgeon removes the thyroid, okay? You can also have some more rare causes. There's some ones we'll talk about that you'll only see in kind of a pediatric population. Post-radiation, there's infiltrative, like certain metal depositions that can affect the function of the parathyroid glands. So that's primary hypoparathyroidism, and then what we'll touch on at the very end of this lecture is resistance to PTH action, which means that the parathyroid glands are functioning, but when the hormone gets out in the bloodstream and goes to the end organs, it's not getting in, okay? So there's an in-organ resistance to that hormone. And what we'll focus on there is pseudohypoparathyroidism, okay? When you have low calcium in the blood, it's important to also rule out magnesium issues. If magnesium is low, that's the problem. It's not necessarily the calcium. The magnesium needs to be fixed. Reasons for low magnesium, one thing I think of right off the bat is alcoholism can cause low magnesium. Of course, the PTH level, that makes sense. We talked about that a lot. And then the vitamin D level. If the vitamin D is low, fixing that alone can, fix the low calcium. And many, many people are vitamin D deficient. So hallmarks of primary hypoparathyroidism, of course, low calcium. Remember this too, high phosphate. We'll talk about some of the, even the dietary restrictions that people sometimes on low calcium have to be on because of the high levels of phosphate. And then a low or undetectable PTH. Okay. So a surgical hypoparathyroidism is fairly common, ranges from 10 to 50%. That range, I think, is just based off of the surgeon. Some people that do more of these, you'd be more in the 10% range, and then less of them, you'd be higher. But most of the time, hypocalcemia following a thyroidectomy is transient, and people kind of bounce back. But it can be a problem for a while. The worst time is 3 days post-op, and it's estimated 6 months following surgery, they start to convert. This is kind of a long-standing problem. This is not transient any longer, okay? Something called hungry bone syndrome you need to be aware of. This often happens in people with very poor renal function who have had long, sustained levels of high calcium in the blood, and their bones are starved, basically, of calcium. So when it's fixed, when the surgery is done, it basically sucks in everything it can, and it can cause this hungry bone syndrome that's important to be able to recognize. Oftentimes people with renal issues, like on dialysis, that have this surgery done, are hospitalized for up to a week to make sure that they keep these levels from going too low. So that's important to keep in mind, but it can present with a severe and diffuse bone pain. Now switching to autoimmune hyperparathyroidism. These are more rare. Remember, these are the ones that typically you'll find in a pediatric office. No one in their 60s is going to present with this. They would have already, been diagnosed. But the age of onset is typically 5 to 9 for the first one here. But these are more rare but important to keep in mind. Typically a referral if it doesn't fit the picture, like if someone having surgery and you're still struggling to figure out what's going on. There's antibodies that can be measured to the parathyroid gland that kind of give you a clue of what's going on there, but an endocrinologist's office is probably where these people would end up. Other causes, I mentioned briefly that there's some deposition of metals that can affect the parathyroid glands. Think of iron deposition in a neonatal DeGeorge syndrome. It comes with a cluster of other things, but it can also cause issues with the parathyroid gland. In Wilson's disease, copper deposition can affect the parathyroid glands. Aluminum deposition can occur in dialysis patients, but this is more rare now because there's some changes done to dialysis fluid that does not include aluminum at same concentrations. So this is not near as common as it used to be. Magnesium depletion, we talked about that briefly, and some of the different GI and renal disorders that can result in magnesium deficiency. So this is the pseudohypoparathyroidism, so this is resistance to PTH action. So the parathyroid hormone is being produced fine, the parathyroid glands are working well, but as that hormone gets to the end organs, it's not, it's not effective for some reason. So there's a resistance to parathyroid hormone. Usually it happens around 8 years of age. Even if you were to give someone parathyroid hormone, they would not respond, okay? It results in low calcium levels and a high PTH, so that's how it would differ from primary hypoparathyroidism. Has high phosphate as well, and it says here 3 different types. If you would mark that out and put 4, that's a typo. There's 1A, 1B, and 2, and then there's also a pseudo-hypoparathyroidism. The way to differentiate between these two is basically whether someone has a phenotypical picture, they have some physical characteristics of the disease or not, and also a response to a test called a urinary cyclic AMP. It's a urine test that's measured in response to or after you've given someone PTH. Okay? So those are kind of the 2 ways as we differentiate these 4 types of pseudohypoparathyroidism. So just briefly go through this, but remember these are quite rare. Type 1A has the phenotypical picture, which I'm going to show you here. So you have a short stature, round face, short neck, missing basically a knuckle when someone makes a fist, so you have that look. Usually these patients are obese and they have subcutaneous ossification. So that's kind of the phenotypical picture of Albright's, and that's type 1A, okay? Type 1B, the resistance to PTH is only in the kidneys, so the bones and the intestines do well with it. It's similar to 1A, but it doesn't have the same physical features of Albright, okay? The test to differentiate between 1A and 1B is this cyclic AMP after giving PTH. So you have type 2 as well. No physical characteristics, but has a normal response to cyclic AMP, whereas the other one has a blunted response to cyclic AMP. And the last one, my favorite of all diagnoses, is pseudo. Why they named it that. But PPHP has the features of Albright's, but the response of urinary in response to urinary cyclic AMP is normal. Okay, so it's not low as it is in 1. So Anyways, I know that is all a little confusing, but that's how to differentiate between the 4 types of pseudohypoparathyroidism. So yeah, the phenotypical picture is only in 1A and pseudohypoparathyroidism. So how to treat low calcium in the blood? Usually it's treated by IV if it's severe. If it's not, you just take calcium over the counter. But it takes quite a bit of calcium to correct the low calcium. So oftentimes, especially if tetany exists, then patients need to be hospitalized and given IV calcium. The thing to take into consideration with low calcium is that it should be done in a very monitored environment when it's being corrected. If it's done too fast, it can affect the airway. There's stridor oftentimes when it's given. IV calcium can irritate the veins, and they need to be on an EKG to monitor for dysrhythmias while being corrected. If you just have kind of more run-of-the-mill chronic hypocalcemia that's not as severe, there's no tetany involved, then it's just given calcium and vitamin D replacement anywhere from 1 to 9 grams per day, depending on the severity. There's different forms of calcium, calcium citrate, calcium carbonate, and also give it along with short-acting vitamin D called Rocaltrol, and then a long-acting vitamin D, which is often given in 50,000 unit doses. Okay. High phosphate, I mentioned earlier, also accompanies this condition, and oftentimes there's dietary restrictions that come with this. Meat, eggs, and dairy products and sodas are high in phosphate, so patients in these situations need to limit the intake of those items. I talked about vitamin D. So that's basically with the treatment. There's also how often you need to monitor patients with low calcium. At the beginning, it's fairly frequently. It makes sense that it would spread out once you've kind of got them level. But the important thing I would throw in there too is that the urinary calcium exam should be done twice yearly, and then the eye exam should be done yearly to monitor for cataract. PTH replacement, I mentioned how it's not approved, but that medication I mentioned called Forteo or teriparatide is used off-label for treatment at times, and they are looking at other forms of PTH to possibly use in the future. But like I said, I don't think any of these have FDA approval as of now that I could find. So I have a couple of practice questions, and then we'll take a break. Okay, guys? Okay, so which of the following patients has laboratory evidence consistent with hypoparathyroidism? You guys can take a shot at it. Anyone else?
Seems like
Any thoughts?
A.
A. Yeah. Does it make sense? Why? Are there any questions? Why not B? It's the magnesium. And then why not C? The vitamin D. And D is also magnesium issue. So that gives you an idea. Okay. Permanent post-operative hypoparathyroidism estimated to develop in what percentage of patients after thyroidectomy? B. And what is that variability based off of? The surgeon. Yeah. So long-term complications of hypoparathyroidism include Yep. Okay, let's take a quick break and then we'll do the thyroid, unless there's questions.